Hi, everyone. Good morning, good afternoon, good evening. Thank you for joining us for our Thursday VMR. My name is Jazz, one of the CPS Solver member here, and it is an absolute joy and privilege for me to co-discuss with Rabih today and with my VMR family. I'm very excited, nervous as well, so I feel like the earlier we start this, the better. So I'm gonna pass it to Rabih.
Jump right in. I absolutely love it. Thank you so much, Jazz. You've been a CP solver through and through for such a long time. I think what would help prove the point is to show people what it says on your shirt. Yes. How long would you get that shirt?
So, funny story behind that. This was actually gifted to me from one of our fantastic third year residents who was actually chief this year for our program. So, she basically was like, you may not be the main clinical problem solvers in the nation, but you were our clinical problem solver dude at our
Oh,
program." So, she was very nice, and it was a very nice gift. I'm going to use this as a good luck charm.
heck yeah. And slowly but surely, you are becoming the clinical problem solvers of the nation as you slowly but surely make a tremendous impact amongst the VMR community in many, many other ways. It really is awesome to be able to discuss this case with you. I still remember when Reza and I were humbly joined at your institution now 2 years ago. Right? Probably like 2 years ago. Is that right?
Oh, I would say probably like two and a half,
Two
three,
and a half.
2.5 years. Yeah.
I admire your precision. You're not gonna let me get away with 2 years, huh? Like two years and 6 months to the day. I love it. I love it. I'm excited. If you're that precise, I think we're gonna do a good job with this case. Speaking of said case, we have a case presenter from the case review committee. Hi, Melody.
Hi everyone. It's nice to meet all of you.
Do you want to tell us a little bit about yourself, if you don't mind?
Oh, sure. So, my name's Melody. I am an international medical graduate from the Philippines, and I graduated last year, and I hope to apply this year for neurology.
Amazing. Neurology, huh? That's so cool. How did you decide neuro?
I think I kind of decided it even during the first year of medical school, where when we were introduced to like the neuroanatomy and all that, and I'm like, oh, this is so cool, and like just to be able to trace these different pathways and all, just
Yeah,
yeah, it's just interesting for me.
that's so cool. And where in the Philippines are you from?
Um, I'm really from Cebu. Not sure if you're familiar with it, yeah, but I studied in Manila for medical school, same where Bettina studied actually.
Yeah. Do you guys know each other?
Yeah, we were from the same batch.
Oh, that's so cool. Look at that. That's amazing. Well, anyone who knows Bettina is a friend of the CP Solvers crew. So welcome, special welcome to you. How was it to work with and interact with the case review committee? What did that feel like?
Yeah, it was actually very helpful because they kind of helped me digest also the case, especially since I guess there are always a lot of info for every case, and they kind of helped me like decide which ones would be important to bring up to the 1 hour session so that we
Yeah.
could highlight some important stuff for that.
Who did you get to work with? Do you remember?
Yeah, I worked with Bettina and Kirtan.
Oh my
And
gosh. Wow. Bettina and Kirtan. Oh, lucky you. I'm a little jealous. That's awesome. Well, a big shout out to Bettina and Kirtan for setting you up for success and for Amanda and Omaima who worked behind the scenes to make it happen. It's really special that we have you here as a result of all that, all of your hard work and all of their organization. Um, well, thank you to Ricardo for scribing and for Deborah for doing the teaching points today. We're excited for it. Melody, whenever you're ready, take it away.
Oh, all right, I could start now. So just a bit of a background, I guess. Well, before I start, I'm sorry, this is maybe or maybe not a neuro case. I guess let's see. Okay, so for this patient today, we have a 56-year-old male. Yes. Okay, let's just add that info that he's right-handed and he's coming in with slowing of speech and word finding difficulties. Would you want any other with a history of present illness too, or do I stop for a while?
I guess um, I think we can take a first stab at this. I'll make it quick. I think first of all, when someone says this patient is right hand dominant, that gives away this is probably going to be a neuro case. But um, so I think my initial framework right now is that with the slowing of speech and word finding difficulties, this is the classic symptoms of a stroke. So I think right now I would be pausing in my diagnostic workup here, and I would be focusing on treatment. And I would basically be doing a stroke code, and kind of getting the CT scanner ready and all that kind of stuff. That's the only thing I have to say right now about this, Robbie, unless you feel differently.
Yeah, no, I'm curious. It's so cool to see how what your reflex is activated. You're like, this person is having slowing speech and word finding difficulties. That has to be a code stroke, right? And that should be your default assumption. And I think any subsequent data may deflect you or push you away. So as you sit here moving towards stroke, what are some of the things that have fooled you that you thought looked like strokes, but turn out to be not strokes?
Oh yeah, happens all the time. And I think one of the things that I've burnt by is actually hypoglycemia.
100%.
So, and then sometimes it's medication intoxication, alcohol intoxication. There's so many that, especially with the word finding difficulty, confabulation, a lot of that it comes from alcohol. So um, I agree with you that we're going to get more data that might change that, but just seeing the chief complaint, I already have my spidey senses tingling in the management reasoning section of that going as well.
Love it. I love the either deliberate or unintentional use of the word tingling in this neurological.
There's gonna be a lot of puns today.
Yeah, let's do it. So, pretend like. So I think it's helpful to read that one liner one more time. 56-year-old right-handed man coming in due to slowing of speech and word finding difficulties. Is there one piece of data that you can subsequently receive that will dramatically reduce the probability of stroke? Think about that for a second. That's a tough question, but it's going to it shows you how there's one piece of data actually that if you get it next, it would make stroke very unlikely.
I feel like it would be the tempo here. If it's like, yeah, I would say if it was hyperacute or acute, hyperacute, I would say this is a stroke. But if we see this is going on for like, hours to days, then this is less likely to be stroke.
100%. What's your sense of the time course based on the chief complaint? What do you think? Do you think it's going to be hyperacute, acute, or subacute?
Ooh, that's tough because I feel like word finding difficulties or slowing of the speech could be from a metabolic or toxin related phenomenon, but it's hard. I feel like slowing of speech, whereas like I think it's hard to guess from here, but if I had to guess, I would probably say it was probably in the acute setting.
Yeah. I think that it goes to show what the difference is between the chief complaint and the HPI. And if a patient came in and was able to describe all this in the first sentence, I would say the time course is more likely subacute to chronic. Because if they truly had a hyperacute devastating event that happened to them so severely and so abruptly, I don't think they'd be able to get much out. And that's the key point in the history is you can get so much from studying when somebody just says, what is in the chief concern? What is the HPI? And the more rich detail that a patient is able to provide, the more likely that there has been time for that rich detail to evolve. So I'm intrigued. I think if we state to the facts, you're absolutely right. This person having word finding difficulties rather than word expressing difficulties really suggests involvement of the central nervous system, likely the contralateral language predominant hemisphere, i.e. the left hemisphere in a right-handed person, most likely. But the amount of detail that he seems to describe makes me wonder whether this has been going on for longer than just a sudden onset syndrome. But it does bring up the conversation we should have briefly of breaking down speech issues. So here we're saying we're getting a sense that this person is has slowing of the speech and word finding difficulties. What are you inclined to translate that into medically? What would you call that speech issue medically?
Aphasia?
Yeah. And so I'd love to learn from you. How do you in your mind break down aphasia versus dysarthria, which is often confusing for people. So tell us,
Yeah,
please.
I'll be honest, neuro is my weakest point
Yeah.
by far. But the way I break down dysarthria and aphasia is basically aphasia is coming from the central nervous system. It's like the wires and the cables, whereas the dysarthria is a muscular problem. It could be a muscular problem, and it's the person having difficulty expressing that speech because of a muscular issue, and that could be neuromuscular junction effects, could be Parkinson's, could be other neurodegenerative situations as well. It could be a stroke too if it took off the brainstem that innervates those muscles of the throat and the larynx. But typically, aphasia usually is like the left side of the cerebellum, or the cerebrum that focuses on the speech center. So that's how I break it down. But I'm no Aaron Berkowitz.
Neither am I, my friend. Although we're mimicking Aaron Berkowitz and we're talking for like 15 minutes on 4 lines. Yeah, I think you nailed it. And for me, it distills down to actually a very simple model. Aphasia is problems knowing what to say. Dysarthria is problems knowing how to say something. So if you're listening to a patient and they're not having a hard time knowing what to say because they can't find the words, or the words that they are saying are illogical and don't make sense, that's a problem with what. Dysarthria is how. The words are chosen correctly, and if written, would be completely logical. But there's a problem with enunciation of the word. So aphasia equals what, and dysarthria equals how. And so I think paying attention now to the time course and to making sure that we're solving the right kind of speech problem, because it's not unheard of for a patient to say they're having word finding difficulties when they actually mean word pronouncing difficulties. So that's what I'm really keenly listening to, is what period of time has this been evolving for? And does this map on more to an aphasia issue or a dysarthria issue? All right, Melody, tell us more.
All right, so in terms of the time frame, so 3 days prior to consult, the patient's wife actually was the one who noted the slowing of speech and the word finding difficulties. And aside from that, though, the patient also complained of intermittent left periorbital pain, which was described as throbbing, 9 out of 10 in severity, and it was temporarily relieved by acetaminophen. But aside from that, there was no headache, no nausea, vomiting, no weakness or numbness anywhere in the extremities or in the body, no facial asymmetry noted, or no slurring of speech, so just slowing. And then in the interim, there was just noted progression of the word finding difficulties, and the patient was only able to answer in short phrases with persistence of the intermittent eye pain. And so a day prior, the patient consulted with an ophthalmologist for the eye pain, and he was advised to consult with a neurologist, which prompted the consult at the ER. So that's the history of present illness. Should I proceed with the past medical, etc.?
I think we can probably fill those boxes in as well.
Okay, it's just short anyway. So he is hypertensive, but it's controlled on losartan and metoprolol. He has a family history of diabetes on the maternal side, while his personal social history, he is a 12-pack-year smoker and an occasional alcoholic beverage drinker. So that's it for no allergies and no like prominent health-related behaviors that should be noted.
Okay, wow. So lots of information came into this aliquot, but mostly what I was able to decipher here was that we have this periorbital intermittent throbbing pain. And we definitely got the time course, and this is, subacute, which now makes the stroke conversation less likely. But there is some type of neural phenomenon going on here where I still feel the central nervous system is probably involved in some way or shape or form here, just because of the speech and the word finding difficulties. And we'll see what the physical exam shows, but I don't really get a flavor of dysarthria in this situation, or maybe a little bit with the slurring of the speech and the facial asymmetry. Or it says no facial asymmetry. So I think what I would be focusing on now is that how can I tie in the periorbital throbbing pain? And I'm trying to think of a vasculitis that can definitely flare up in the blood vessels in the brain, and then also the periorbital. And infection also seems less likely. I would also, it doesn't, looking at his med list, losartan and metoprolol don't seem like the common culprits to be a toxin. And it seems like, occasional alcoholic drinker. So you want to, really ask specifically, like, how much are you drinking, even when you are drinking occasionally? Because even binge alcohol users can have vitamin and mineral deficiencies. So that's what I'd be focusing on. And the periorbital swelling is just, and pain is interesting, because I honestly haven't seen it too much. And I really associate it with either a migraine, and this could be an atypical migraine or a complex migraine that could be associated with this, with an aura, or I associate it with like infections, and then also vascular, like a vascular phenomenon. But to be honest, I'm right now, I feel a little stuck of like where to really hone in on.
Yeah, no, I think it's true of the circumstance I think you're in, where you don't really know what signal, and it's hard to know what to lead with. So we have a pain syndrome around the eye, and then we have a focal neurological syndrome. And I agree with you, it sounds a lot like more likely to be aphasia than dysarthria. And so aphasia, as Yaz outlined in the chat, will localize to the left cortical region. Then you can be more specific depending on what kind of aphasia it is, frontal or temporal, based on the exam. So you got pathology likely involving the left frontotemporal cortex, and then a pain around the eye. So what do you think? What are you inclined to invest your diagnostic energy? What do you think is going to get you more in return on your investment? The neuro stuff or the pain? What do you think?
Oh, definitely the neuro stuff. Like
Yeah.
I think the pain, like I think whatever's causing the neuro stuff is probably contribute to the pain as well.
100%.
So
Agreed. Like whatever you see in that area, you're probably like, oh, I can make a leap, and say that that's causing the pain. So if we were to make a list of the unique features of this disease, is that it's involving that area, and uniquely it's occurring over a few days. So what's your gut sense on the kinds of things that cause diseases in that area that evolve over days? Just sort of like big picture categories. What do you think might happen in that area?
and specifically in the neurology. Okay, yeah.
Yeah.
So it's hard. I wouldn't consider this like a typical meningitis or encephalitis type of
Yeah.
picture, because the 3 days is I would say too long. So it could be an indolent infection, but less likely. So I think infection I'm getting less of a flavor from. But specifically, what could be is a vascular phenomenon can brew over 3 days, not necessarily a stroke, but like a vasculitis, especially a flare. And then I think depending on the toxin, I mean, we're not really getting that picture from him, especially with the med list, but if he's taking something illicitly, it can happen. It's usually more acute, but depending on, let's say he starts feeling unwell, starts getting a kidney injury, certain toxin starts to accumulate over time. So that would be something on there. But yeah, I don't, a neuromuscular problem can also go into that. A mass formation that's just gotten big enough now it's causing a mass effect. But to be honest, 3 days or like that subacute category is something that I often don't think too much about. Don't see it as often, is what I'm trying to say.
Yeah, gosh, I hope you and I aren't seeing it very often because it shouldn't come to us in most instances, you know. Here's another really maybe helpful way to think about it is, what do you think the chances that his MRI will show something in that area is?
Oof. I feel like if it's some type of encephalomelia going on, that we could see that type of changes on the MRI. I don't think the CT scan is going to show much. It could show a mass, but I don't. I think the MRI would probably be the best bet. I just don't know. I think the chances of an MRI showing that is 50-50. I think there are a few things I want to rule out with an MRI, but for example, a seizure disorder wouldn't explain the periorbital stuff, but can explain the word finding difficulties and that you could potentially sometimes can see swelling or edema in the brain parenchyma. But yeah, so I'd say I'm not slam dunk like, yes, MRI is definitely going to show something. This might be a situation where we may need an LP as well or an
Yeah.
EEG, but I think MRI, I'm definitely will be getting an MRI for this patient.
Yeah, 100%. 100%. Gosh, I love discussing these cases, and I think it all hinges so much on the time course. And if you go to a different space, which is the pain around the eye, and take a simplistic approach and say that this person's head hurts, if you ask yourself, is this a primary or a secondary headache? The only primary headache that is associated with neurological symptoms is a migraine. And the symptoms with a migraine are usually no more than an hour of aura. This has been going on for 3 days. So this cannot be a primary headache syndrome. So it must be a secondary headache syndrome defined as pathology either in the skull base or in the brain itself. And if you ask yourself what kinds of things that are secondary headache syndromes what kinds of diseases exist there, and there's only really 3 kinds of diseases. There's space occupying diseases, so a mass can cause a headache. There's vascular diseases, usually venous thrombosis, but also vasculitis. And then finally, there are inflammatory diseases. So if you were to say, okay, there's a headache involved, I'm worried about it, what could I find? You'll probably find a space occupying lesion, or you'll find a vascular issue. And you ask yourself, do any of those map onto the brain stuff? And the answer is absolutely yes. I think we all on CP Solvers have developed a very good approach to thinking about hyperacute neurological syndromes with the 3 S's, seizure, stroke, and sugar. And I think it's also helpful in parallel to develop a short list of subacute CNS issues defined as evolving over days. And that list is subacute focal, I should say, neurological issues. This is subacute in a very focal area or in the left frontal and temporal lobe. And that list is a space occupying disease process. There's something there, be it blood from a hematoma, be it from an abscess or a cancer, demyelinating disease like multiple sclerosis or acute disseminated encephalomyelitis and stuff like that. And then finally, venous sinus thrombosis. So I think when you hear headache and focal neurosymptoms that is subacute, mass becomes the most likely and most concerning thing, be it blood, be it pus, be it cancer, followed by, importantly, excluding venous sinus thrombosis. Demyelinating disease doesn't usually affect the cortex, which would be invoked here in the setting of language issues. So for me, I gotta tell you, because of the fact that it's focal and the fact that it's subacute, which brings the differential of mass, venous thrombosis, and demyelination, all 3 of those things show up on MRI. So right now, with this information, and we have the exam to come, the investment in imaging and the anticipated return on investment for me is high. And that's a good thing because it helps you figure out how you're going to crystallize this problem. But don't be wrong. It could be an abscess. It could be hematoma. It could be a benign tumor, a malignant tumor. It could be venous sinus thrombosis. Still many things. But because of its focality and because of its slow progression, I think the radiology is going to be a big return on investment here. It may not be on the CT, it may be an MRI, but I would really be invested in that and start to pick up on what clues elsewhere might help me figure out what one of those three things is. Any questions about that? Cool. All right, Melody, tell us more, please.
All right, so let's go to the physical exam. So for the vital signs, his temperature is 36.8, heart rate is 60, RR is 20, 98% SpO2, and his BP is 160/80 at the ER. And then his systemic PE was unremarkable. For his neuro exam, the patient was awake, conversant. He follows commands. He was oriented to 3 spheres. He had good concentration and attention. He, however, was non-fluent. He had word-finding difficulties, and however, repetition was preserved. So he was able to name, repeat, and comprehend. He had good immediate memory, however, impaired recent and remote memory. And then he also had left-right confusion, finger agnosia, dysgraphia, and acalcula. He had no osteoagnosis, no gravisthesia, no prosopagnosia or anosognosia. He had, however, ideational and ideomotor apraxia, but no constructional or dressing apraxia. And he had no neglect. So just a bit for the cranial nerves. For cranial nerve 2, he had a right homonymous inferior quadrantanopsia. However, there was no fundoscopic exam done. Pupils were 3 millimeters, equally brisk reactive to light, no ptosis, gaze was midline, and there was direct and consensual light reflex, no RAPD, and there was full and equal EOMs. Other cranial nerves were really unremarkable. In terms of the motor exam, he had no atrophy, fasciculations, it was normotonic, it was not spastic or rigid. He, however, had a minimal pronator drift at the right upper extremity. In terms of the strength, though, it was 5 out of 5 in all extremities, and reflexes was 2+, also on all, upper and lower. He had no Babinski sign, no negative Babinski, Tromner's, Hoffman's. He had also unremarkable sensory, cerebellar, and meningeal signs. So that's what I have for the physical exam.
So I think this aliquot really, how do I say this? Really embraced my neurophobia. So, let me see if I can. So there's something going on in the right eye that no, but jokes aside, I think what this hones in on is like that optic chiasm pathway. And with the one thing I will say is that after the physical exam, I am more convinced that this, like Rabih said from the earlier aliquot, that this is not, I don't see any signs of generalized confusion, and this is less likely to be encephalopathy, so like a universal type of process. And I think this is more focal to the left side or the communication-based aphasia. I don't, unless I missed it, I probably did, but I don't get any sense of dysarthria, and I think this is probably aphasia. The right coming up, like I'm not even gonna pronounce it, but the quadrontosophosia, basically, I honestly am not even gonna try to remember what that pathway was, but I remember it. I think if I'm remembering correctly, it is before the optic chiasm. Am I right there, Rabih?
You know, a good rule of thumb is to take the words and flip them. So right homonymous inferior quadrantanopia implies a left superior cortical problem. So it's like literally like if this part of your visual field is abnormal, then this part of your brain is looking at it. And of course, it's a very complicated visual pathway to map out, but that's a good kind of cheat way. So since it's a right inferior homonymous quadrantopia, it is likely reflective of a left superior cortical problem. So you're looking at the, as Aaron would love to hear, he'd probably vomit when I say this. The left top of the brain is as focal as I can say. By the way, I spent a whole hour with Aaron at Morning Report today because we work both at the VA, and he was teaching me all these fine nuances about cranial nerve 3, and here we are localizing it to left top of brain. That's what I can tell you. But keep going.
No, I was gonna say it's better than me saying it's above. It's before the optic chiasm.
You know, can I be real with you, Jazz? I had the exact same reaction that you did, and I think that realistically speaking, is a frontline provider tasked with these subtle observations? I'd say probably not. No. I think there's two things you can learn from this. Is one, how these very fancy things that are almost exclusively human, like recognizing fingers, crunching numbers, doing these very human-like tasks, are cortical phenomena. They're in the cortex, the most human element of our brain. And I think all that you're really tasked to learn from this as a generalist is to recognize that when patients are telling you that I'm bumping into things, or I can't quite do math very well, or I can't tell left from right anymore, I think it's very easy to be dismissive of those patients when they don't have more obvious neurological dysfunction, obvious meaning that something that you and I should pick up. And so while it is possible that you may be dealing with without an organic cause to those symptoms, just recognize the subtlety of cortical disease and how it takes a nuanced neurology exam to pick it up. And for me, I think you and I would probably definitely pick up the speech issue and maybe pick up the visual field, though I've missed visual fields in many circumstances. But I think they all are crowding in the left cortical regions of the brain. And you could even be more specific and try to localize the aphasia as an expressive aphasia. He's having a hard time saying words. And I know people use a lot of clues to say, is it with repetition or without? I actually don't know them. So all I can take it is I'm pretty confident this person has a cortical disease process involving the left parietal lobe, maybe the left frontal, and maybe the left temporal. And I think what a neurologist would be able to do is to visualize how big this problem is, because I think they would have more precision in actually being confident which of those three lobes it's in. And the bigger the localization, if you go from frontal to temporal, the more intriguing it becomes as to what can be so big. So right now, I'm pretty confident there's something happening in left top of brain. But what I don't know is how big that is, you know? Like, I don't know if it's massive all the way from the frontal lobe back to the temporal, or if it's this small. I don't know that yet. So I'm curious, what other thoughts do you have to add? And if you were taking care of this patient right there as a frontline provider, what do you think you might do practically next?
Yeah, so in terms of thoughts, I just, wanted to say that one thing when I looked at all of those fancy words was that it seems like I did not get any sign of monocular vision loss, which means that the optic nerve was fine. And then I didn't see any evidence of exam findings of like the macular being spared, which means that the occipital cortex was fine. After that, I was like, it was a mess. But I think one thing I'm confident about is that given the time course, it seems less likely to be vascular for what this is presenting as. And again, infection, unless it's like a slow growing abscess, it seems less likely. Inflammatory demyelinating, I feel like similar situations. And you asked me last aliquot how confident or like what do you think the MRI is going to show? is it going to show anything? I think after hearing that physical exam, I feel like I'm now probably from 50% MRI is going to show something, it's probably 85%, 90% that the MRI is going to show something exactly in those regions that you suggested. So to answer your other question of what I would do next, I would try to figure out, like, while I'm waiting for the MRI, I would definitely try to get a CT first to see if it does show something that we can work up as an MRI. And then if the assumption is this is probably a neoplasm, I would want to ask him, like, is he up to date on his age-based cancer screening? Is there any other risk factors that we probably forgot to ask or mention in the first in the first time we met with the patient? And I would also make sure that I would do frequent neuro exams, make sure that, remember, if this is a mass, it's clearly growing to the point where now he's having symptoms. And if he's having symptoms, I don't want those symptoms to progress to the point where he has his brainstem herniates. So I would want to do frequent neuro checks, tell the nursing staff and everyone that is taking care of this patient that, hey, this patient can decompensate quickly. So those are the things I'll be doing next.
I love it. All right, Melody, tell us more, please.
Okay, so for the next part would be some of the labs. So I got his CBC. His hemoglobin is 14.9, hematocrit 0.44, WBC 8.95, platelet 208. His total cholesterol was 170, LDL 89, HDL 49.5, triglycerides 209. His fasting blood sugar was 106.2, HbA1c of 5.8. He had an ECG done, which showed normal sinus rhythm. So the next part would be my last part. So would you want me to continue or do I stop for a bit?
Maybe we can just reflect briefly, Jess. What did this aliquot do for you? What do you think?
Yeah, I think this aliquot was reassuring as the one word, if I had to use it. It basically makes me wonder that, makes me say that, okay, there's not a systemic imprint on this workup. So what I'm more confident after seeing this workup so far is that this is isolated to the central nervous system. And now my percentage has gone up from 85 to probably 99%. It's funny, I started from 50 to 80 and now 99.
Hopefully I didn't lead you astray. This turns out to be the 1% that you didn't lock.
But to be fair though, sorry,
yeah.
I was just gonna say, to be fair though, like, we haven't gotten any flavor of anything else. Triglyceride of 209 does not impress me. I feel like I have that after I eat ice cream. So
I think, folks, as you start to learn the medicine in this case, I hope that you start to see the hidden messages of the lessons that you can learn from by just listening to your patient. When somebody is able to tell so much of their story in the chief concern, it's never acute, almost never. Small thing. You can predict the time course from the conversation. And I think the other big thing that Justice emphasized is you have to be very careful, and you can no longer rely on your patient in this situation to tell you a rich history when they have word finding difficulties. And when they have word finding difficulties, imagine if they have a massive systemic problem. How are they going to tell you? They won't be able to tell you. So I was holding my breath, literally waiting to see, is the white count low because there's undiagnosed HIV? Is the platelet super high because the patient has an abscess? Or is the kidney function really bad and this person has press? So they can't tell you. So this situation is crucial before you lock your brain on just word finding difficulties to recognize that word finding difficulties limit your patients to tell you a full story. So you have to pay very close attention to collapse. So I completely agree with you, Jas. Melody, this case is so well presented because you could have easily chose not to pause on this aliquot because it's not so fancy, but it actually is the most important aliquot so far. It makes us now analyze this case not as left front brain problem, unknown system. It makes us be very confident that this is top left brain problem, full stop. And that full stop is the most progress we've made since you started sharing the story with us. So thank you for doing that. All right, tell us more. And Aaron, if you're watching this, please forgive me.
All right, so for the other imaging, he did not get a CT scan done. So what we have is a plain cranial MRI with MRA. So our most awaited imaging study. So this is the result. So he had multiple acute left middle cerebral artery territory ischemic infarcts with mild hemorrhagic conversion in the left temporal, occipital, and middle frontal gyrus infarcts. He had significant stenosis in the distal M1 to proximal M2 segments of the left MCA, which may be due to atherosclerosis or thrombus or embolus. He had mild chronic bilateral frontoparietal white matter, microvascular white matter changes, and negative for mass lesion, aneurysm, or vascular malformation. So that was his MRI. Afterwards, a few days after, they did a 2D echo. However, the results were normal. So normal cavity size and wall thickness, structurally normal valves, and no wall motion abnormalities. They also did a carotid duplex scan, which was a normal carotid Doppler study. There was interrogate flow of both vertebral arteries. So that's all for the imaging.
And then, Melody, I just want to confirm, is there one more aliquot after this?
Oh, no more. It's just the diagnosis and like what happened after in the course of the hospital, just in case if you were,
Okay.
you know.
Okay. So basically, the next aliquot will reveal the diagnosis, correct?
Yes.
Okay, thank you. I guess my next question is, so when I first read multiple acute ischemic infarcts, the first question that I had was a TTE as well. Like, is this an embolic phenomenon coming from the heart? A normal TTE, to be honest, I still, if this is, this is a moment where I would go down to the radiologist's room and say, hey, like, is there any evidence that you can see that this is more embolic, or is it thrombotic, or is there something else that you can kind of help me out here with? The aspect that I feel like I'm stuck with here is that if it was an embolic form, where's it coming from? And the heart, just because the TTE is normal and the chances of this may coming from the heart is high, like a murmur on exam or something like that, I actually would go for a TEEE to make sure that this is not coming from the heart. But there's something else about this finding that's it's also interesting, is a significant stenosis in the distal M1 to proximal M2. So, sure, could this be atherosclerosis? Sure, but why all of a sudden, and why specifically there? Is he prone to this? Is this a vascular phenomenon going on? So, for example, a vasculitis that put this patient at risk for advanced stenosis or advanced narrowing of those arteries. So that's what I'll be thinking about right now. And I'm going to ask myself, like, where are these multiple infarcts coming from? And usually the first thing I think of is the heart, because it's the pump. And then the second thing I think of is there like a tumor, that somewhere in the body that is releasing micro emboli like that. But again, the workup of before the brain imaging did not really reveal much. So I guess before just rambling on, before I pass it back to Rabih, I think the one thing I would say here is I would probably work this patient up with like an autoimmune serology, just to make sure that there's no vasculitis that's making this patient prone to this type of vascular disease. Because the MRI is, in my opinion, is showing a vascular phenomenon for sure with the ischemic infarcts, but is there a risk factor that's leading to that? Rabih?
Yeah, no, I completely agree with you. I think that you have a thrombus here, and then you have the hemorrhagic conversion. I wonder if the hemorrhagic conversion accounts for a subacute presentation and the headache, but we never know. And I think if you take a simplistic approach of saying there's thrombus here, you first have to ask what is the source of the thrombus? Is it from the pump, cardioembolism? Is it from the pipes implying that it's actually a blood vessel issue from atherosclerosis or vasculitis or vasculopathy? or is it the plasma, meaning that something within the actual blood is causing hypercoagulability, like cancer? So I really try to solve these thrombosis cases by thinking of the 3 Ps. Is there pump issue, either a tumor in the heart or a thrombus from atrial fibrillation? Is this a pipe issue? The pipe has atherosclerosis in it, or the pipe is inflamed, or plasma. There is a hypercoagulable issue within the blood itself that's causing the patient to clot. So how can we go forward here? I think we have to study closely the pattern of thrombosis. This is very focal. It's in a specific area, all distal to a stenosis in the M1 branch. So I think the probability that this represents a pipe issue, and if we figure out what's the stenosis in the M1 branch, we'll probably solve this case, right? Because there's nothing else going on anywhere else except distal to that stenosis, implying significance of that stenosis. However, of course, it could very be possible that the patient has TTE negative cardioembolism, which is often actually that they're having intermittent atrial fibrillation, which is why these patients get put on Zio patches. But I think the question for me is what causes M1 stenosis, and what causes pipe issues? And the vast majority of pipe issues are atherosclerotic in nature. And in some populations in the world, the risk of atherosclerosis is much higher in general and less dependent on diabetes and on hypertension. Gurleen, one of our team members, is working on atherosclerotic risk factors in South Asians, and has really illuminated my understanding of the rate of atherosclerotic disease inherently in the population without the additional risk factors. So I think that would be the most common scenario, but you're right. You have to wonder, could this be a vasculopathy or a vasculitic lesion? The hole in those hypotheses is they're relatively rare diseases, and they usually present with multifocal findings rather than in a single distribution. So I would say that odds are this is atherosclerosis, intracranial atherosclerosis. And depending on your resources, you might choose to invest in dedicated vessel imaging with contrast to exclude vasculitis, or you might say, let me treat for atherosclerosis and watch the patient with dual antiplatelet therapy and statin and see what happens. I think that's the helpful approach is pumps, pipes, plasma. There's a pipe problem here. There's a stenosis. Most common pipe problem is atherosclerosis. Others are vasculitis and vasculopathy, base rate atherosclerosis, even without diabetes and with controlled lipids. Yeah. Melody, tell us, what did you all think?
Yeah, actually, so at the end of it, they also couldn't find like the real source. So I think they kind of also just I think they also believed that it was either atherosclerosis or cardioembolic, although I think they're leaning towards atherosclerosis. So their final diagnosis was acute CVD infarct, left MCA territory, large vessel obstruction with hemorrhagic conversion. They said probably cardioembolic in the setting of steno-occlusive disease. So that was their final diagnosis. But they unfortunately weren't able to do autoimmune serology. So all the tests for possible autoimmune diseases weren't done in the hospital. I think it's more of a financial problem, I guess, on our end. So I think that's why they weren't able to do that. So what they did was mostly really just secondary stroke prevention. So they gave aspirin, atorvastatin, citicoline. But he was only on single antiplatelet use due to the hemorrhagic conversion. I think they were hesitant to immediately put him on the dual. And the plan was just for a possible intracranial stenting at day 14 post-ictus, once he's already cleared for the dual antiplatelet therapy. And well, if you're also curious, so during his hospital stay, he kind of recovered. So on his second day in the hospital, the visual field deficits resolved. And then also the next day, so on the third hospital day, the complete Gerstmann, so all the four symptoms, signs, were also improved. So there was no more left-right confusion. But the others were still a bit there. And he was eventually discharged, and he was for outpatient follow-up. Otherwise, I think it's because because of his clinical improvement, then you're kind of just following him up throughout and see where it goes, and like not really looking into where it came from, I think. So it's more of like symptomatic part. Yeah. And then in terms of do I share some of the things I've learned also for this case? Okay, so actually it was nice. It was really cool when you guys had to discuss the case and I knew the answers to some of the cases. It was fun that way because it was like, oh, this is interesting. That's how they thought of it. And I kind of have like some of the clues or like some of the answers to the case. So this was a really nice experience. So, and I really learned a lot from this case, even just preparing for it. So I think I've seen this also in the chat, wherein one of the things I enjoy is localizing it and like just merging all the symptoms and signs of the patient, which could lead us to where the lesion is. So like for this patient, the signs and symptoms actually point towards a left MCA lesion. So I think it was mentioned a while ago wherein there was a kind of aphasia. So for this patient, since he was able to repeat things, but he was kind of slow, his is considered a transcortical motor aphasia. I'm not sure if you're familiar with that diagram wherein, there's like can comprehend, can repeat, and then they'll tell you what kind of aphasia it is. Yeah, so I just followed through that. And then for him, it was a transcortical motor aphasia, which means that the lesion is most probably in the anterior left frontal lobe, just right outside Broca's, which is usually supplied by the ACA or a watershed region between ACA and MCA. And then aside from the aphasia, he had Gerstmann syndrome. So this would mean that there's a lesion in the angular gyrus, which is also supplied by the left MCA. And he had the apraxia, so the ideational and ideomotor apraxia, which tells us that he has a lesion somewhere in the left parietal region, which is also supplied by the left MCA. And his quadrantanopia, so his lesion would probably be in the left parietal optic radiations, so behind the optic chiasm, supplied also by the left MCA. So it's just really cool for me to see, like, if we just break down all the signs and symptoms, and it shows us that it actually points to a left MCA lesion. So it's something I learned, that how physical exam can tell us so much also, aside from just like waiting for the MRI also. And I think for the periorbital pain, it could have also been the hemorrhagic conversion. And I also discussed this with a attending, and he also kind of thought that it could also be the edema from the ischemia, which caused the periorbital pain, and probably not like the usual headache that we would expect from edema. It could have presented as periorbital pain. So these are just some of the things that I learned from preparing this case. So thank you so much for the opportunity also to share it with you guys. I hope you had fun.
I'm gonna say that I don't like I have very severe neurophobia, but Melody, your teaching was very well done and your case was just amazing. Thank you so much.
Melody, I'm becoming more and more grateful of the instances where people come and present sneaky presentations of common diseases. I think that if I were to change one thing about VMR, it would be that we would start to do this kind of case more often, instead of the poems and esoteric craziness that we often discuss, which honestly is kind of addictive and really fun. Oh, and only when I emerge rationally do I realize like just how powerful these cases are. And you made us overcome our VMR bias, because this is actually it's the most common intracranial disease in people, full stop. And when you have such an unusual presentation of it, the fact that it is so common still makes it incredibly likely. And I think one subtlety that I will emphasize that you had is you seem to be a little bit hesitant that there was no clear answer. And I would commend you on that, because that's actually real life. neurologists often have a hard time distinguishing in situ thrombosis from occult cardioembolism. So much so that they make an educated guess and put the patient on heart monitoring for up to a month to try to figure it out. So the tension that you're living with there that you articulated is not a deficiency in this case. It's a reflection of the struggle it is to know, was this person having paroxysmal episodes of atrial fibrillation, which we did not see, or was it intracranial atherosclerosis? And no test can tell you for sure. The only way you can know is if you put a heart monitor on for 2 weeks, even 4 weeks. And of course, resources can limit that. So I think that that's real life, really is. But thank you. This was a really, really fun journey to go on. And hopefully I will get a little bit better in my cortical localization than the left top of brain. But Jas, how did it feel for you to discuss it?
I will be honest, when I heard it was a neuro case, I got a little bit more nervous. But it was fun. I think learned a lot, and next time I'll do better than before the optic chiasm.
Heck yeah. I think everyone in CP Solver has come to love and admire your light and humorous approach to life. And I think I admire that deeply too. And you know, I am 10 years out of attending and I could not localize this more to left top of brain. So I'm right there with you, my friend. Right there with you. We all have a lot to learn, especially in neuro. But like you said, in many instances in many parts of the world, it is our job as generalists to field these calls, and these cases help us grow better and better and better. So we're ready for the actual real life scenarios, you know. All right, Deborah, take it away, my friend.
Hi, everyone. Congratulations, Jas, for the first discussion. We are super happy and proud of you. And I said in the middle of the case that you could act like you lost your internet and leave the Zoom, but you didn't. So we are super happy. Thank you, Melody, for the case. I'll try to go from some quick teaching points. With slowing speech, Jas told that the first thing that crossed his mind was about stroke, and then what could, besides stroke, what could mimic one stroke, like hypoglycemia, medication intoxication, alcohol intoxication. And we need to check if the cheek complaint and the history, and when the patient can give more details, that could maybe mean that it's more subacute of chronic. And then Rabih gave us a great differential about aphasia and dysarthria. And aphasia, it's what to say, and dysarthria is how to say. And that for me was a great pearl. And in this case, we were thinking about the tempo, about acute and subacute. And acute, we always think about the S, sugar, stroke, and seizure. Subacute could be something, a space of occupation like blood, abscess, a cancer, a demyelinating disease, or could be like a venous sinus thrombosis. And due to different diagnoses in all those cases, we should order an MRI. And then there, probably when we had the patient on physical exams, there was a right monomus inferior quadrant apnea. We learned that means that it's in the left superior cortical problem, so was in the top left of the brain. I think saying that it's better to remember. And in this case, the patient had multiple acute infarcts, so we think about an embolic phenomenon. And in this stenosis, it could be a vasculitis, a tumor, and we could order like a autoimmune serology. And the part part was that Rabih said about the blood vessels issue, that we have 3 Ps: pump, pipe, and plasma. Pump could be a tumor, atrial fibrillation, pipe could be atherosclerosis, and plasma could be a hypercoagulation process. So yeah, thank you, everyone. I hope to see you all tomorrow.
Deborah, it's amazing to remember where you started and to watch you do teaching points now. It's unbelievable. So short, so sweet, so on the point. Absolutely amazing. Thank you all for an amazing hour. I really hope to see you tomorrow for RLR. Bye.
Bye.